colleagues from UCSF here with us today, led by Dr. Theologis, with Drs. Burch, Clark, and Dr. Bervin, talking about something that's the bane of our existence in deformity surgery, that's adjacent segment collapses and some ways out of it. So without much further ado, welcome all, and thank you, UCSF, for leading the charge today. And Dr. Theologis, I think you'll do the introductions.
Yes, sir. Good morning, and thank you for that kind introduction. Appreciate the opportunity to present this journal club on cement augmentation for prevention of proximal junctional failure in adult spinal deformity surgeries. As a quick way of background, just to set the stage, we'll define the issue at hand. So PJK, proximal junctional kyphosis, occurs in a large percentage of patients who undergo long posterior thoracolumbar fusions, particularly to the pelvis. The cost of revision operations for these surgeries are quite staggering, as you can see there. Mechanical risk factors for PJK can be grouped into three major categories: disruption of the posterior soft tissues, bone screw interface failure, and vertebral fractures. The vertebral fractures will be the point of this talk. These compression fractures are one mechanism, and they can result in very devastating complications, including neural, especially if they occur in an early time frame. And preventive strategies really are aimed at augmentation of vertebral bodies. There's a variety of ways this can be done: putting cement in the upper instrumented vertebra, the UIV only, putting it at UIV +1 to the level superadjacent cranially, and then you can do it at both. You can do it at multiple levels. So there's a lot of different ways. And so the real question here is, what's the evidence in support or against it? And so we have 4 papers that we've chosen to present. They're listed here. I won't, for the sake of time, I won't say the names of each, but just wanted to give a quick introduction of each of the presenters. So the first we presented with Rafid, Kasir, which is one of our fellows. The second will also be presented by one of our fellows, Zach Sharfman. These are my 2 favorite fellows that we've had at UCSF, so I'm glad they are participating. And then 2 of our residents who are going into spine, Jennifer O'Donnell and AJ Aga, will round out the last 2. So thank you guys for your willingness to contribute, and I look forward to the discussion. So Rafid, take it away.
Thank you very much. Thank you for having us again. It's always a pleasure to present. The first article is use of vertebroplasty to prevent proximal junctional fractures in adult deformity surgery, biomechanical cadaver study. This was published out of Johns Hopkins in the Spine Journal in 2013. And as Dr. Theologis mentioned, my name is Rafid Kasir. I'm one of the fellows. In order to address the cost and health burden, the author's purpose was to examine cement augmentation at the top level and the top 2 levels, top level +1, in preventing PJK. Their methods, this was a biomechanical study. The authors obtained 21 fresh frozen cadavers from the Maryland State Anatomy Board. They examined the cadavers and excluded 1 for metastatic prostate cancer, which involved the vertebrae, as well as excluded 2 for damage during testing. The authors harvested spines from T7 to L5 and all 18 remaining cadavers, and they instrumented from T10 to L5 and divided them into 3 groups, 6 each. The first group, they did not perform a vertebroplasty, which was a control group. The second group, they cemented the T10 level, which was the upper instrumented level. And the third group, they augmented the T10 level as well as the upper instrumented level +1, which was T9. Mechanical testing was performed on each specimen by inserting them into an apparatus that applied an anteriorly directed load until failure for 5 millimeters per minute for 15 millimeters. Some of the, or they halted the test if the apparatus reached 15 millimeter mark without failure. The outcomes were the load to failure, as well as the presence of compression fractures on subsequent examinations. This was a baseline group. These were the baseline parameters for each cadaver. This is a table showing all 18 cadavers and the groups they were divided into: control UIV, UIV plus 1. Here we see the cause of death for each specimen, and as well as a DEXA score for each. They didn't include their p-value in this DEXA score in this table, but the p-value was similar. Was greater than 0.05. So DEXA scores were similar among the groups. This is an X-ray showing the instrumentation of group 3. Spines were instrumented from T10 to L5, and cement augmentation was performed at the T10 level by inserting the cement first and then inserting the screws while the cement was hardening. And the cement was introduced into the T9 level by introducing a 5 millimeter tap and then introducing cement into the vertebral body. 5.5 millimeter titanium rods were used in this study, and pedicle screw sizes varied depending on the size of the pedicle. After instrumenting each spine, the authors created a special mold. Here we see on the picture to the left, it's an acrylic mold. The purple is the kind of acrylic paste that hardened, and this increased the surface area between the external testing device and the actual spine itself to disperse the forces equally across all points. They then inserted the spines and the acrylic mold into the testing device. Here we see on the picture to the right, on the left half of that picture, we see an anteriorly directed wedging force with axial compression. And again, they tested this at 5 millimeters a minute. The apparatus would move until failure or until 15 millimeters were reached. This is an example of the deformation curve that was created for each specimen. Here we see the load on the y-axis and the displacement on the x-axis. And we see as the load increases, the displacement increases until a peak threshold is reached, at which point the load needed to displace the spine dramatically decreased. This was called an inflection point in this study, and that was defined as the peak load to failure. The results of this study showed that are summarized in this table. We see the 3 groups: control, upper instrumented vertebrae group, and UIV plus 1. We see that the peak load to failure confidence intervals all intersected. So there was no statistically significant difference in the peak load to failure for each group. However, if we look to the right of the table, the number of fractures were statistically significantly different in the groups. Again, they do not include the p-values in these tables, but the p-value was 0.021 in comparing the 1 fracture in the upper instrumented vertebrae plus 1 group to the other groups. And if we go to the next slide, we can see the actual fractures that occurred. And the top 6 lines of this table are the control group. We see fractures occurred in each specimen. Fractures occurred in almost all the specimens in the next group, but in the UIV plus 1 group, there was only 1 fracture. And we see the distribution of fractures were also different. In the control group, you had a mixture of T9 and T10, the upper instrumented and the upper instrumented plus 1 group vertebrae. In the UIV group, you had the fractures or the same risk, but increased the risk to the super adjacent vertebrae. And then actually the T8, which was even the UIV plus 2 vertebrae in the 3rd group, did have 1 fracture. So cementing, two conclusions were drawn from this paper. Cementing the UIV alone does not decrease the risk of PJF, but actually just transfers that risk to the super adjacent level in this biomechanical study. Therefore, the authors recommend cement augmentation of the UIV plus 1 in preventing adjacent level fractures. Thank you very much.
Thanks, Rafid. You want to give us your take on the paper, what you liked about it, what you didn't, and what you took away from it, how it may change your practice if you had read this?
Yeah, absolutely. I like the paper. I think it's not perfect. It's hard to mimic what happens in the actual body with a biomechanical study, but I think they did a good job in directing the axial forces anteriorly. But as we know, patients twist, they flex, they have lateral bending. Those all can contribute to changes in the instrumented levels and the levels above. I think that the conclusions were logical, and I think that actually it was pretty evident that the UIV +1 group had less fractures overall. My question is, if they increase the numbers from 6 to 12 in each group, maybe we would see a few more fractures in the T8 level in that UIV +1, which makes you wonder, should we be instrumenting UIV +2, for example? But yeah. That's a different study.
Rafid, let me ask, you've seen a diversity of approaches to what to do at the upper instrument vertebra, both in the upper thoracic spine as well as thoracolumbar. Now you're ending your year as our fellow. What are you going to be doing? Because as you know, at UCSF, this isn't the way that everybody prevents PJK with cement augmentation.
Thank you, Dr.
Which technique are you doing, Doc?
Yeah, I will be doing this technique. I think I've seen many different techniques, cementing the UIV +1. I think I like this the most. I think the outcomes are good. I also like using pedicle hooks in the upper thoracic spine, especially at that kyphotic transition above the apex. That has been effective as well in preventing some PJK. And then, of course, there are all sorts of other soft tissue augmentation procedures we use that I will have to look at the data at specifically in terms of creating a tension band in the posterior ligamentous structures.
Hey, Rafid, nice job. What do you think the mechanism of injury is? Like, what do you think the mechanism of the fracture is? Like, how do people get this?
I'm not sure what you're getting at, Dr. Burch. I mean, it's a compression fracture from compression at the anterior column and distraction at the posterior column.
Well, I guess what I'm trying to say is, I think, like, I've often wondered, why people get PJK after we realign them, and is it motion that is it aberrant motion that they are sort of doing after surgery? Is it the way we prevent them from moving, and then they have to move through their, in the T10 of the pelvis, they have to move differently through their thoracolumbar spine, and so they kind of flex at the junction between the native spine and the instrumented spine, or is it more that we've taken out the extensor mechanism of the spine and they just sit in a flex position, and it's more of a biomechanical creep issue where they just sit hunched forward and then slowly deform their spine, and it's probably both. And so when we think about like why it happens, it often you back that up and say, well, how can I prevent that from happening? And that's really what I was getting at. I just wondered what your thoughts were.
Yeah, I think it's definitely multifactorial, and there's it's a diverse patient group. I mean, there are many risk factors. Overcorrecting, I think, would certainly increase that creep theory. Patients want to get back to their prior position sometimes. I mean, so sometimes you have to split the difference. But I think it's very multifactorial.
Yeah, I think this is a really insightful statement by Dr. Burch, and that is the classic failure mechanisms for adjacent segment failure are bony, ligamentous, or combinations. And that's reflective of the patient's underlying disease pattern, obviously a myopathy, meaning a deficiency of extensor muscles, a lack of postural awareness is a very significant contributing factor. And I think this article really just pinpoints the bony element and ignores the ligamentous part. On the methodological part, my question was, did the authors actually standardize the amount of cement infiltration? And pertinent to what Dr. Burch said very insightfully, was it a axial loading mechanism or a 3D loading mechanism where there's kind of a flexion component involved? I kind of missed that.
Yeah, thanks for clarifying, Dr. Chapman. So the cement used was 2 to 2.5 milliliters in each pedicle bilaterally in the vertebral body. And the axial load was slightly directed anterior to the midline, to the middle column. So there was a flexion load. I think I would have to look back at the paper, but I think it was 1 centimeter anterior to the midline of the column.
Because again, the devil's in the detail, and again, that's not more patients, meaning like close to 100% get adjacent segment failures is a small miracle, and really requires all factors, bony, ligamentous, and muscle reactivation, meaning postural awareness, to be met. And so it's a really complex and challenging thing, especially when we end in the lower thoracic spine. So now thanks for that outlook.
I'll just add to discussion here is one of the real limitations, of course, of the cadaveric study is the absence of biology. So as Jens has pointed out, the absence of the true tension band, but also one of my real concerns about this to me is really, and I've always said that this is a pretty obvious study, that yes, we could avoid the UIV +1 fracturing if we cement it. But having said that, that's not necessarily what we're seeing in vivo. What we're tending to see is the UIV fracturing and ligamentous complex combinations. What I'm concerned about cementing adjacent vertebra is I've seen some rapid osteonecrosis and end plate necrosis when we cement 2 adjacent vertebra. And I'm very concerned about that being something that contributes to the biology problem here, especially with 2.5 cc's at adjacent levels. Has anybody else seen a rapid end plate osteonecrosis or disc degeneration at the vertebra between 2 cemented vertebrae?
Absolutely. Very well said. Thank you.
So I do a lot of this. I do a lot of UIV +1, and admittedly, I don't look for it, but I'm going to push back on your observation a little bit. What are your numbers?
Yeah, it's a good question. We wrote about this with Mauro. 12% was the radiograph, or was the incidence of revision surgery. But in terms of how many of them were really involving osteonecrosis, most of those at that time didn't have. Most of those only had UIV cemented and not the UIV +1. So I don't have a good answer for how often we're seeing osteonecrosis. But when it happens, I think it can be pretty dramatic.
Well, that's a great discussion. I think there are definitely benefits to the 2-level cement augmentation. And I think there's more data that's needed to determine the negative side effects of the cement augmentation, especially on the blood flow and the osteonecrosis phenomenon. But after that original biomechanical study by Kabesh and his group, here at UCSF, myself and Dr. Burch did a clinical study looking at the clinical efficacy of this 2-level approach. And this will be presented by Zachary Sharfman. He's one of our fellows going to private practice in Los Angeles, and Dr. Burch will be moderating. So Zach, thanks for joining, and thanks for putting this together. And I'll run the slides.
Thank you again for having me. As Dr. Theologis said, I'm going to be presenting this article published by Dr. Theologis and Dr. Burch out of the UCSF group in 2015. Title of the article is Prevention of Acute Proximal Junctional Fractures After Long Thoracolumbar Posterior Fusions for Adult Spinal Deformity using 2-level cement augmentation at the upper instrumented vertebra and the vertebra 1 level proximal to the upper instrumented vertebra. Just as an aside to the title, I think that Dr. Theologis mentioned this a second ago. This study was really performed as a historical narrative to answer the question, we're experiencing proximal junctional fractures above these long realignment constructs in adult deformity patients. And we're throwing every technique and idea we have to prevent this complication. Now let's take a historic look back and see what's actually happening to these patients, how they're doing in terms of fractures, and how they're doing in terms of patient-reported outcome scores. And I think that gives some historical context to what was going on at the time after the biomechanical study came out that Rafid Kasir presented a second ago. So the study's purpose: this study was performed to evaluate the incidence of postoperative proximal junctional fractures associated with revision operations and clinical outcomes of adults with spinal deformity who underwent posterior fusions and instrumentation from the thoracolumbar junction to the pelvis with or without two-level cement augmentation at the upper instrumented vertebra and the UIV+1. So the methods: this was a retrospective cohort study. Data was collected between 2008 and 2013. Patients in this study were consecutive patients. 5 or more levels were fused, and constructs ended in the thoracolumbar junction, defined as between L2 and T9. And there was a minimum of 6 months clinical and radiographic follow-up. I think this point is important because when we're seeing proximal junctional fractures, the majority of them occur in the first 6 months. So although the follow-up is relatively short in terms of time, I think it encapsulates that critical period for follow-up. 3 groups were created for this study. There was the no cement group, which can act as our control. There was the other cement constructs, where anything but UIV and UIV+1 were cemented. And then there was the UIV and UIV+1 group. So demographics: 51 patients were ultimately included in this study, with an average age of 65 years old. The top of the constructs ended at T12 for all patients who received 2-level cement, whereas in the UIV was at various levels, most commonly at T10, in the no cement and other cement groups. The purpose of the demographic slide here is kind of to demonstrate that although this is a historical narrative, it's not a perfect study, and our groups were not completely heterogeneous. They were not all T10 to pelvis constructs. Rather, some of them ended in, lower in the thoracolumbar junction. However, in our UIV+1 group, we ended at T10 consistently. In terms of follow-up, we're also not heterogeneous between groups, as this is a historical narrative, and you can kind of see the natural progression of the cement technique that was used, which is the response to recognizing and trying to prevent this problem. Initially, no cement was used, and they have the longest follow-up. Another cement protocol was used, and they have the second longest follow-up. And finally, the 2-level cement was routinely used, and as such, they have the shortest follow-up period. And it demonstrates our, historical response to this issue and our desire to solve this problem for patients and the often devastating outcomes of PJK. So looking at the results, this chart demonstrates the radiographic measurements, some of the radiographic measurements performed. And I think the highlighted box here is trying to demonstrate that there was a significant difference between groups in terms of the first post-operative measurement of thoracic kyphosis. In the no cement group, there was a significant change in our postoperative thoracic kyphosis as compared to our 2-level cement and our other cement group. So it's quite clear that our cement, that in the early postoperative period, cement augmentation does limit that thoracic kyphosis, but on final postoperative measurements, there was no difference. So this, again, goes back to what Dr. Burch mentioned earlier about creep and deformation over time, and possibly a slow progression of fractures and settling of the spine after we do these long construct deformity corrections. And cement clearly affects that in the early phase, However, that effect was not maintained over the long term at our final postoperative X-ray. Otherwise, there were no significant differences in terms of radiographic measurements between the cement groups. I think this slide gets to the meat of the paper in terms of, what we care about in improving patient care and improving outcomes. No one wants to take someone back to the operating room. And this slide is not only looking at fractures, but it's really looking at the revision rate and how often we have to take people back. So revision for fracture was 0% versus 19% in 2-level cement group versus the other group. And this was significant. In the other cement group, patients were 13 times more likely than the 2-level cement group to have a revision for proximal junctional fractures. And patients treated with no cement were 9 times more likely to have revision surgery for proximal junctional fractures than those treated with 2-level cement. All this is to say that we take people back to the operating room more often when they are treated without that 2-level cement construct in this cohort during this study period. This slide goes to demonstrate the each individual revision. The first column up here is the no cement group, followed by the other, and followed by the 2-level cement augmentation group. You can see that although the numbers of revisions are relatively low, the percent of the patients in each group that underwent revision was significant in terms of, you don't want you don't want to be performing this number of revisions on your patients for proximal junctional fractures. Of note, in the 2-level cement group as well as the cement group, these were atraumatic fractures, and these occur slowly over time. And the time to fracture, I think, is important in the 2-level cement group, which was after 6 months. However, in the no cement group, as expected, we have these early fractures that occur at less than 6 months in all cases. This also happened in the other group, that all fractures happened at less than 6 months, most often not at the cemented level. Now, finally, in terms of results, this study interestingly takes into account outcome scores. It's not only do we take people back to the operating room and have revision surgeries, or do we have radiographic measurements, but also how are our patients doing? How are they telling us they're doing? Of note, in terms of our EQ VAS pain scores, patients treated with cement at any in the UIV in the 2-level cement construct had significantly improved pain scores as compared to our other groups. In terms of our EQ5D disability scores, we see that all our patients are improving, which likely speaks to the change in our alignment and a more harmoniously aligned spine, and patients are doing better in those positions. And then again, when we look at our ODI score as well as our VAS pain score, we're seeing in the ODI significantly improved pain in terms of in the UIV +1 group, and VAS pain scores are better after cement is inserted in both the other cement and 2-level construct, but not in the no cement group. And that might speak to cement augmentation allowing for less pain as you begin your healing process. As expected, this study does have several limitations. It's a retrospective case series. It's consecutive patients, and the patients aren't matched perfectly. There is limited follow-up. Again, this study does capture that 6-month important time period where fractures are most likely to occur. There are various construct lengths, and there's no preoperative DEXA scans to tell us if the bone quality in each group is similar. Despite these limitations, I think that this study gives us, our first real picture at what we were doing to prevent this problem and how that progression occurred, and the actual outcomes in terms of revision rate, patient-reported outcome scores, and radiographic outcomes. And if we can marry those 3 things together and find the best strategy to avoid proximal junctional fractures, revisions for patients, and improve our patients' outcome scores, I think we'll, on average, have happier patients and less revisions, less burden on our medical care system here, and we can take from there and keep advancing. So in terms of discussion, 2-level cement augmentation in deformity patients was compared with 2 other groups here. We saw a significant reduction in the revision rate in our 2-level cement group at 0% versus 19% in our other groups. And we also noticed that there were decreased patient-reported outcome pain scores with cement versus no cement in this study. In terms of a quick discussion, I think that although the data is not perfect here, and every physician needs to be informed on the quality of the data, I think this is high-quality evidence in my mind demonstrating that patients did better with some type of cement augmentation, both in terms of their patient-reported outcome scores and in terms of proximal junctional fractures. And I'll take that into account when I perform any long construct fusions ending in the thoracolumbar junction in my practice.
Thanks, Zach. That was a great overview. Just a couple of comments. So, this paper really started out based on observation, and it does go back to, I think, even an earlier paper that Kalkabesh wrote, even before 2013, kind of talking about the advantages of cement augmentation. And, back in the 2008 through 2012 corridor, we were overcorrecting people all the time, and then we would see these, catastrophic failures. And I was certainly guilty of that. And so trying to prevent that, we started off with 1-level cement and then, UIV and UIV +1. And there was this just dramatic drop off, at least in my practice, of the fracture complication. It doesn't obviously prevent ligamentous instability, but it does knock down the fracture, adjacent level fractures and PJF. And it was done to kind of get the information out there that this actually works. And as time goes on, I realized that this is not, when you do this technique in the operating room, it's not the presence of cement, it's the volume of cement that you put in. So any study that says cement doesn't work, you really have to look back and say, well, how much cement was added at the UIV +1. And really what I'm getting at is that when you really fill the vertebral bodies up with a kyphoplasty and a vertebroplasty, it takes a lot of time in the operating room to do it, and to do it carefully. And it really slows the sort of the progression of the case down. But every time I don't do it, I'm always disappointed at 6 weeks or at 3 months, because there's always some hint that there's a bit of a compression fracture. And I will say that as we've dialed back the amount of alignment correction over time, we're seeing less and less. And there are times now where I don't do it all the time, but it's rare. And so this is a technique that I pretty much have incorporated into all my long constructs that end at the thoracolumbar junction. So don't do it at T3 or T2, but always do it when I stop at 12, 11, or 10. So those are my comments.
Yeah, thank you for this paper and the honest discussion, Shane. Also, really important insights. I just wanted to ask, in terms of the methodology used, why did you not use the ROC kind of Hounsfield unit determination as a surrogate? That would have been important. And the second thing I want clarification is there a safe time period where we don't see this adjacent segment failure happening? You mentioned 6 months, but I see various numbers batted around. Can you kind of look at an apex time that if we make it past that, we kind of have a reasonable assurance that nothing bad will happen?
Yeah, so the Hounsfield units, that's been a recent development. I don't think the time when we were kind of writing this up, it was in vogue. And, There's bone density and then there's bone strength, and those are two different parameters. Tony Keaveney and I have written papers about that. And so there's different aspects of it. And so bone density is not the only parameter. It's the structure of the bone as well, not just the density of the bone. And then in terms of your second question about the apex, I think once you get past 3 months, I think it's getting back to my earlier comments, the extensor mechanism has recovered. The patients are standing in more of a physiologic alignment, using their back muscles again, and they're not slouching forward due to pain or just due to inability to extend. And so I think once that extensor mechanism recovers, I think you're out of the risk for either getting creep or, I'm convinced these people do it trying to get out of bed. I'm convinced these, patients do it when they're sitting at the table and they're reaching forward for something. I've recently, begun biomechanical, kinematic studies with a camera system, to look at how people move after surgery. And you can almost see it watching somebody try to bend down and tie their shoes. So, if you do that early, you can see the patients who have short hamstrings who can't bend forward, so they have to bend through their thoracic spine. So I think that once you get past that 3-month mark, patients have appreciated what they can and can't do, perhaps, and are not pushing the limits. So.
Yeah, great discussion, guys. There's a lot of different ways that this technique can be done. And in terms of vertebroplasty, kyphoplasty at both of the levels, Shane and I do a similar approach where we put fenestrated screws in at T10. We do not expose the more proximal level at T9, but instead we do a kind of minimally invasive perk through the fascia and then do the kyphoplasty in that way, so we don't disrupt the extensor mechanisms. Neither he or I use any posterior ligamentous augmentation, and our PJK and PJF rates are quite low. I just want to draw your attention to this surgical video that we just put out. It's going to be it's in press right now, but it does walk through. It's about a 7-minute video on how to perform this step by step. So if you're more interested in performing this in your own operating room, please check this out. So the next study will be presented by Jennifer O'Donnell. She's one of our residents. She's going to be going into spine, and I'm happy that she chose to go into spine. I think she's matched for fellowship, and she'll be a wonderful fellow. This is going to be moderated by Dr. Burvin. And so for the sake of time, Jen, take it away.
Great. Thank you, Dr. Theologis. Good morning, everyone. The title here is The Effect of Prophylactic Vertebroplasty on the Incidence of PJK and PJF Following Posterior Spinal Fusion. This is a 5-year follow-up study coming out of the group at Johns Hopkins that was published in 2017 in the Spine Journal. So they're looking at whether prophylactic vertebroplasty of UIV and UIV +1 prevents PJK or failure in these long segment thoracolumbar posterior spinal fusions, and specifically looking at 5-year follow-up for prospective cohort, which they had previously published about at the 2-year follow-up. As mentioned, it's a single center prospectively collected cohort study. They have a minimum of 5 years of follow-up for 95% of the patients. Patients were initially enrolled between 2005 and 2008. All of them had adult spinal deformity, were older than 40 years old, had at least 5 vertebral levels of the thoracolumbar spine fused, and all of them had some evidence of low bone density, either preoperative DEXA score or intraoperative assessment of poor bone quality. And that was just based on clinical judgment. So they performed radiographic review as well as clinical outcome scores at preoperative, postoperative, 2-year, and 5 years. So this is reporting on those 5-year results. And all patients underwent posterior spinal fusion with a standard midline approach. Regarding the prophylactic vertebroplasty, the authors used a standardized amount of cement, 2 milliliters, and they had previously described this technique. They drilled through the pedicle, then tapped it, placed the cement, and then placed the pedicle screws. And their outcome measures, first, the primary outcome measures were prevalence of proximal junctional kyphosis, as well as any complications related to vertebroplasty. So that was any cement emboli, extravasation of the cement. And the secondary outcomes were first the clinical outcome scores. So they used SRS-22, ODI, and short form 36. And then for radiographic data, they looked at both coronal and sagittal alignment, and thoracic kyphosis and lumbar lordosis. So I'll report on first the primary and then the secondary outcomes. And overall, they initially had enrolled 41 patients. 39 of them were retained at 5-year follow-up for 95% retention. And out of these, 11 patients had developed proximal junctional kyphosis by the 5-year mark. 3 of them had occurred in the first 2 years, and then an additional 8 had occurred more long-term failures. So to think about that in the percent, so overall they had a proximal junctional kyphosis rate of 28%. Which is about on par with previously reported numbers. And as mentioned, majority of those occurring later between 2 and 5 years. And in total, 2 patients, so 5%, had developed proximal junctional failure, although the authors had defined this only as within the first 6 months, having unplanned reoperation for proximal junctional failure. And again, 2 of these patients required revision surgery, and those are the failures. Overall, no complications had occurred related to the vertebroplasty. And so out of these 39 patients, so far their rate is 0%. Looking at their secondary outcomes, they found no significant differences in any clinical outcome scores and no significant differences in any of the radiographic outcomes. However, the authors here actually used the first postoperative as their baseline for then measuring the changes in different alignment numbers, which is discussed in some letters to the editor that they went back and forth in the Spine Journal. Ultimately, they felt that settling needs to be accounted for first and then use that as a baseline. Others do it differently, using the preoperative as their baseline. Overall, complications were 36 what they called major complications, 16 were minor complications. Among these, the most common complication was proximal junctional kyphosis, with a total of 11. And there was, so most of these complications were not related to vertebroplasty, none of them were intraoperative vertebroplasty complications. But there was one in which the vertebral compression fracture occurred cranial to the vertebroplasty level, suggesting that you may just be moving that weak point of the construct just more cranial. So there are some strengths of the study. It has this is at the time was the longest term follow-up from any previous studies. It was single center, well standardized with a single surgeon doing all of these procedures. Of course, this is also a limitation in that it's a single center, single surgeon study, and there was no control group. So we're only comparing to historical numbers. In conclusion, the authors conclude prophylactic vertebroplasty does have a low rate of clinically significant complications, but it did not appear to have any effect on development of PJK or late failure due to PJK at the 5-year follow-up. And so just moving into the discussion, at least for my take on this study, I do think that some of their methodology had varied. And so it's unclear to me about the radiographic data, if that was truly not significant across the 5 years. But overall, their percent of people that had proximal junctional kyphosis was not significantly lowered, as had been previously shown, like in the article that Zach had presented.
Thanks, Jen.
Jennifer, great presentation. Just continuing the introduction to Jennifer. So she's our senior resident that was going on to Emory next year for her fellowship, and she'll see even more diversity of approaches to dealing with common problems there. Jennifer, one of the observations here, this study we often quote as an example of sort of giving up on the problem, almost saying, well, golly, no matter what we do, it seems to not work over time. One of the observations here that I've had trouble with and I've asked Carol about is the lack of correlation between clinical outcome and PJK or even PJF. Are the numbers too small? Or we've got a couple of studies now. One of the studies out of St. Louis also concluded the same thing, that PJK is a radiographic finding, but there's really not a big clinical outcome. I'll tell you, in my experience, it's clinically significant, but we've got a couple of studies that don't show clinical difference. Why do you think that is?
Yeah, I think, in my opinion, this study is a little small. I know it's difficult to get long-term follow-up like this, but for something that is not occurring at very high rates, we probably need larger studies still.
Let me ask a question, and that is from Dr. Davis. Randy Davis, always good to have you. Having personally gone through a very traumatic period of an adverse litigation around the death of 2 of my patients with cementing intraoperatively, he asked the questions, why don't we just have this done percutaneously by interventional radiologists before or after surgery when the patients are not experiencing additional insult from the dissection or the injection of the cement. So any thoughts on doing this by interventional radiology at a later point or preemptively?
Jen, you want to take a first shot at that? Okay.
I was going to just comment. I think it's a great idea. In fact, I think that biomechanically getting the cement to harden first, and then drilling and tapping into the cement and putting the screws in after the cement's hardened is better. There's evidence from the tumor literature about plating a humerus fracture, cementing first, letting it harden. So I think there's some biomechanical evidence that it would be better to do that. But I think, logistically, it's hard to pull off for the patient. But and I'm not sure about insurance qualifications there on every patient. But I think it's a great idea.
Well, great. Just for the sake of time, I think we should move on to the last paper. This is going to be presented by AJ. He's one of our 3rd-year residents. He's going to be going also into spine surgery, so keep an eye out for his name when he's interviewing next year. And it's going to be moderated by Dr. Aaron Clark, one of the neurosurgeons here at UCSF. He's my right-hand man, wingman, one of my good friends, and we do all complex cases together. So thanks, guys, for participating, and look forward to this paper. Go ahead, AJ.
Hi, everyone. So I'll be presenting the Ramani review on the efficacy of prophylactic vertebroplasty for presenting proximal junctional complications after spinal fusion. The aim of this study was to essentially summarize the available data on the effects of prophylactic vertebroplasty on rates of PJK, proximal junctional fracture, which is PJF, F, and then proximal junction failure, which is a PJF. And so this was a systematic review that was done without analysis, without meta-analysis, and this was mostly because there was a small number of studies that were included with variable kind of methods, and so this kind of precluded any inferential analyses. They searched the above listed databases for studies that looked at BVP, as well as their outcomes and the adverse effects. So their primary outcome was looking at PJK, and then they included any definition of PJK that the papers had used. In terms of their secondary outcomes, they looked at proximal junctional fracture, failure, cement extravasation, as well as any adverse events. In terms of their exclusion criteria, they were looking at mostly at adult patients. Any studies that were pretty limited in their surgical studies, surgical details available, they were excluded. And then any patients who were undergoing vertebroplasty for compression fractures, those were excluded as well, as well as other review articles, non-English papers, as well as small case reports. They employed a JBI bias risk, as well as it used 2 independent reviewers, and the third one to essentially include studies and resolve any disagreements between the studies that should be included. And so of the results, they had 829 total articles that were identified. 8 met the final inclusion criteria for a total of 685 patients. There were about half the patients in the cohorts underwent the PVP, and about the other half did not have this at the time of spinal fusion. 5 of these studies were comparative. 2 of these studies were actually just the 2 and 5 year marks, the Martin and Ramon paper, which I'll go through later, and then an additional longitudinal cohort study. So going into the tabulations here, you can see these are the study characteristics that they included, the 5 comparative ones, and then the 3 single cohort ones, as well as the Martin and Ramon papers, which are the 2 and 5 year marks of the same cohort. You can see kind of overall, these are generally small sample size studies, as have kind of been remarked on earlier in this presentations. The mean ages for these patients really spanned from the 50s to 70s, with the majority in their 60s and 70s. The majority of these patients were female, and the follow-up ranged from 13.5 months to 67.5 months. Of note, there were 3 studies that had significant differences, age differences between their PVP cohort and their non-vertebroplasty cohort, seen in the larger red box. And then the Gabriel study had significant differences in their sex distributions between the treatment arms. So again, just suggesting that these studies are not perfect, they're limited, and they have potential demographic differences between the groups that may confound the results. And then here is the study that looks at some of the surgical details. The average instrumented vertebra levels was from 5 to 9.9. The majority of these patients had their UIV ending in the thoracic spine. And of the studies that did report on the lower instrumented vertebra, most of these had pelvic fixation. Of note, in the outline box there, you can see the heart study. Again, there are significant differences in the treatment arms based on their UIV level. So the ones getting the non-PVP treatment arms had their thoracic spine as their UIV, as opposed to being a lumbar UIV for their PVP groups. And now going to the outcomes. So here you can see the different things that they looked at, the PJK, the fracture, and then the failure rates. So 5 studies reported on the PJK rates in total. And 2 of these reported lower PJK rates in those who used the vertebroplasty. You can see that the Zachary paper essentially had half the rate of PJK in their VP group. The Hahn paper showed no differences between the groups. And interestingly, you can see that there was increase in PJK rates over the 2 to 5 year span for the Martin Ramon cohort, suggesting that this is a process that may play out over many, many months to years. And so studies that have shorter follow-up periods may be missing some of these events. In terms of the studies that looked at fracture, there were 5 of those. 2 of those studies in the red box there in the middle column reported lower fracture rates in their vertebroplastic groups. 1 study had the equal rates, and the other study showed higher rates, interestingly. The Iodine study reported no fractures in their total 24-month long follow-up period. For failures, 5 studies were looking at this and reported on it, with 2 of the studies reporting the lower rates in their vertebroplasty groups. The Han study showed no differences. Interestingly, the heart study shows which did not report on PJK, but did show a higher rate of fracture in the PV group, went on to show that there was a lower rate of failure, although this might just be due to the pretty low sample size that they employed in their study. There was no increase in the amount of fracture in the Martin and Rahman group, despite having an increase in the PJK rates over the 5-year time point. This might be somewhat just based on their definition that they used, which was failure within the first 6 months. So they may not have been including anything beyond that in this tabulation. Now going on to some of the secondary outcomes they looked at, these were including some of the alignment parameters and degrees, which for the most part were not showing too much differences across the groups. However, when you look at the revision rates, you do see some significant changes between the groups that had the vertebroplasty and those who did not. You can see that most of them did report a decrease in revision rates in those 2 groups, suggesting that it may be protective against failure and revision. As far as cement extravasation, there were 4 studies that reported on this. The Zygorakis paper reported a very high rate of cement extravasation, as high as 48% in patients who had undergone the procedure. 4.2% of these patients had radiographic evidence of cement emboli, but all of these patients were asymptomatic per their report. The 44% that you see there is a little bit of a mischaracterization, as this kind of included all complications in the postoperative period for this group, which none of them really appeared to be due to the procedure itself of the vertebroplasty. And so that's a little bit of a mischaracterization in the chart. And then the Martin Rahman cohorts both showed very low rates of cement extrav, all of which had no sequela. When you look over to the threat to neurologic function, so any kind of neurologic injury or damage, you can see that all the studies that reported on had relatively low rates. In the Han paper that does show some evidence of this, there was a failure in one of the patients that had a vertebroplasty, and then in the group that had no vertebroplasty, there were 3 failures, and these patients all had neurologic motor deficits that were permanent. So in conclusion, the authors state that the results are inconclusive to suggest that it's a superior technique. And this is mostly due to the kind of statistical significance, variability across the different studies, as well as the different methods and definitions used. However, if you look at just the studies that looked at comparative methods, you can kind of see it summarized here, where 2/3 seem to show that there was a reduction in the PJK. About half of them showed a reduction in the fracture risk, and then 2 of them showed a decrease in the amount of failures, and all of them did seem to show a decrease in the revision rate. So although there may be small studies with significant I would say issues with the methodology, there does seem to suggest that there may be some potential here that may be better elucidated on bigger studies. In terms of the kind of safety profile, all of these studies showed relatively low rates, except for one of cement extravasation, and very little neurologic injuries or symptomatic emboli from the procedure itself, suggesting that the procedure is relatively safe, despite maybe some of these complications that can arise. So in terms of the limitations of this study in particular, it's a limited number of studies included. They were small sample sizes. They had a lack of prospective data and included variable definitions. And so that may have confounded some of their analysis, as well as some of the differences in the demographic groups that were included in the study. One thing to note also was that there was some studies in this paper that used posterior ligamentous augmentation alongside the vertebroplasty. And so this may be another thing that confounds some of the study, as that might be an additional augment that further improves the stability of the spine and is not necessarily representative across all the studies that were used. So overall, I think it's a study that is good, but it's somewhat just a function of the limited studies available. But it suggests, I think, a good potential for this to be used in the with good effect. But one must be aware of how to use it, how to do it safely, and how to deal with the complications that may arise.
Well, thank you, AJ. That was really a great presentation of this study. I agree with you. It's an interesting study. I think it really amounts to a summary of what's been written so far about this. And combining this with everything that we've heard today from other presenters really does indicate that there is a lack of data, particularly reproducible, consistent data to either support or not support the use of this technique, in spite of it being very compelling. And it appears that there's a lot of interest in performing this technique, and maybe even performed fairly regularly in practice. My question to you is, considering this, if you had unlimited resources and could design the perfect study to answer this question, should we be doing cement augmentation, UIV and UIV +1 and deformity surgery, how would you design that?
Yeah, so that's a great question. I think the going back to the Theologis and Dr. Burch paper, I think is a good kind of model for it. I think looking at different levels over time, hopefully being able to just expand that the sample size to be a bigger one would be important. I think it also would be important to just look at longer follow-up periods too, because I think the Raman data suggests that there is an increase in PJK over time, even as far as many, many years out. So I think ideally what you're looking at is a study that, has different treatment arms. They're all standardized. You can look at different amount of levels being used. You would expand that profile of the follow-up time to a much greater time point, to hopefully years. And then also, I think the profile of the safety is important to try to establish, because I think that's kind of what we're all wondering too, as part of this procedure. And there seems to be quite a difference between kind of radiographic complications per se, or the evidence of cement extravasation, versus actual neurologic injury. So I think having those be a more standardized follow-up parameter to track would be important across the treatment arms that were used.
Great, thank you, and thanks to everybody.
Thank you, UCSF. Great discussion points, really thorough analysis. It's such a pleasure to have you and having this all-star team put their heads together. We look to you to lead the way, so look forward to our next time together. Thank you, Alekos. Thank you, Team UCSF.